Hi, and welcome to our first meeting of our readmission task force here at the DRHA. My name is Denny, and I'm leading this task force, and I'm joined here. I'm a cardiac nurse for DRHA. I'm also the chairperson and facilitator for the organization's readmission task force. Today, our task force is comprised of Elda, a fellow nurse at DRHA. Hello, Elda. Russell,
hello.
DRHA social worker. Hello, Russell. Katie. And Jennifer. Katie's a DRHA case manager. Hi, Katie. And then Jennifer is also a DRHA task force member, however, is unable to be here today, so I'll be speaking on her behalf. The readmission committee has noticed that a high volume of our patients readmitted within 30 days of discharge are those with a congestive heart failure diagnosis. Based on data collected in a 2013 study by Krumholtz et al., heart failure is a very common contributing factor to not only hospital readmission, resulting in increased mortality rates. It has been recommended by clinicians in our organization that a program be implemented in which patients' blood pressure, weight, and heart rate can be monitored on an outpatient basis. This would allow for clinicians to intervene prior to the potential exacerbation of heart failure. In order to efficiently develop this program, the group has been tasked with collecting data from hospital records about patients who have been readmitted. According to a study published in 2012 by Peterson, DeMoro, Goodman, and Kaplan, data from multiple sources can be critical to the optimization of both informatics and medical research. The question then becomes what level of information is shareable and to what degree. Hospital administration would like to investigate the option of hiring caregivers for patients who do not have home support, which will eventually lead to obvious discussions surrounding financial responsibility. Elda?
Hi, thank you, Danny, and thank you for being patient with the technical difficulties we've been challenging through our. First, I would like to address the HIPAA we have, although nanochips may be beneficial. I would like to share a direct quote from the U.S. Department of Health and Human Services, understanding information privacy, so it may widen our understanding on health information privacy and HIPAA concerns on this meeting. The HIPAA privacy rule provides federal protections for individual identifiable health information held by covered identities and their business associates and gives patients an array of rights with respect to the information. At the same time, the privacy rule is balanced so that it permits the disclosure of health information needed for patient care and other important purposes. As a readmission task force member and with the nursing committee, we're here to discuss ethical issues and privacy. With the same token, trying to encourage nanochips on patients for the monitoring and prevention of congestive heart failure. The committee is asked to collect the data from patients who have had frequent hospital admissions. Although it is the most good act in the interest of patients and health society, according to the U.S. Department of Health and Human Services, it becomes a great concern for privacy breach when assessing hospital workers without patient's authorization or consent, or consents the institute a considerable threat to their person. Patients will need to be informed and educated about the need and use of electronic health records and nanochips for those. I'm sorry, I'm just having a little trouble here gliding through. Patients will need to be informed and educated and the need of use of electronic health records and nanochips for those patients who do not have caregivers at home and need closer monitoring. This will require new policies, regulations needed for individual privacy, safety, and ethical use, as quoted in.
Elda, are you still with us?
Should we move on to Russell?
Sure.
Okay, go ahead, Russell.
Hello, my name is Russell. I'm on the readmission task force for this project, and I've been asked to discuss some of the potential ethical issues that may arise with the use of nanotechnologies. The purpose of this study, again, is the implementation of the biochip into the wrist of the patient that would monitor and relay vital health information to remote location in order to reduce chronic heart failure or CHF exacerbation and reduce readmission to the hospital. Fortunately, telemonitoring in the area of cardiology is already in effect with the use of pacemakers and implanted defibrillators. According to an article by Dr. Shocks, these devices automatically transfer all diagnostic data to the cardiologist over a mobile phone network at least once a day, and immediately in the case of a critical event, even notifying the patient to allow them to perform any pre-planned interventions. It would be our intent to utilize this existing technology and replace the sensor with the nanobiochip. Of course, with any device that gathers and sends information, the ethical collection of the information as well as the use of this information can cause some specific questions to arise. The Fair Information Practice Act of 1973 set up guidelines for the collection of patient data, which include 1. Not to use information for a different use other than intended. 2. Not to make the information available to any unauthorized third party. 3. Not to collect information secretly. 4. To provide a way for the patient to know how the information collected will be used. And 5. To provide a way for the patient to correct or amend that information. Although the HIPAA law expands upon these guidelines, they are a good starting point to begin with. Dr. Raj Bawa wrote a paper addressing the ethical dimensions of nanomedicine and states that different ethical issues arise from diagnostic versus therapeutic nanomedicines, as well as interventions performed with nanomedicines, which can raise similar questions to that of stem cell research and genetic therapy, including the questions of human dignity, human enhancements versus human purity, and of course social justice issues. For our discussions, we are only going to use the diagnostic property of nanotechnology. All these patients would be voluntarily and would be required to give informed consent after receiving appropriate education about the program, informed of the increased personal responsibility that they must take on, and be informed of the potential health risks and benefits. The patient will be informed that the chip will be used for diagnostic purposes only, recording vital signs such as blood pressure, heart rate, weight, and possibly oxygen saturation levels. The chip will not be used to track the patient's whereabouts nor transmit any information about the patient's genetic markers or personal lifestyle. The patient should be given the option of receiving a copy email of any information that is sent via the biochip to the facility in order to allow the patient to ensure that there is no additional information being sent. In addition, this also allows the patient to monitor their own vital signs daily. The patient, of course, will be allowed to terminate any participation in the program at any time. Another potential issue that will need to be investigated will be any issues brought up with the patient's insurance companies, such as the company refusing to pay for hospitalization if the patient ignores a critical event warning, or if the patient decides to go to the hospital due to a mechanical error or possible false readings from the chip. Then there is also the issue with the information itself, how it will be stored and how it can be used. Simpson wrote an article on ethics and information technology, points out that information can create or prevent harm if used by the, quote, right people. But the problem, of course, is deciding and identifying exactly who the right people are. This can actually cause more harm than good, and may increase liability and privacy concerns. Therefore, we must decide what information will be transferred into the patient electronic health record, who will have access during the monitoring phase, and how we will be notified if the patient is readmitted into the hospital. Unfortunately, the more issues that are identified and addressed, even more unknown issues can arise as the program progresses. Therefore, it is important for everyone in the study to remember what Staggers and company had said, that we are and will always remain the advocates for patient safety and adhere to our ethical integrity and standards. Thank you.
Thank you, Russell. So Jennifer couldn't be with us today, so I'm going to go ahead and speak on her behalf. In considering the implementation of a program to monitor the health status of congestive heart failure patients to reduce the readmission rates for Desert Regional Health Alliance, we must consider if there are any possible environmental factors which may pose as obstacles or a threat to our patients' health and/or community. The World Health Organization published an article online in 2014 entitled Environmental Health, which defines environmental health and factors as those that pertain to the physical, chemical, and biological aspects that can directly affect health, and its measures that reinforce the capacity to do no harm by focusing on disease prevention and creating health-supporting environments. In contemplating this philosophy, we must reflect on what aspects of the CHF nanochips monitoring program has the propensity to produce positive outcomes and those which may cause direct harm to our patients. Nanotechnology can provide treatment alternatives to individuals to assist in improving the overall quality of life and their day-to-day function. In an article entitled Nanotechnology, the Coming Revolution, written by Staggers, McCaskey, Brazelton, and Kennedy in 2008, they provide evidence on how the utilization of implantable nanotechnology can assist in monitoring glucose levels and providing insulin based on monitoring. In addition, they provide evidence of how nanotechnology is aiding in the prediction of impending seizure activity, and based on this, the monitoring device is able to administer medication to prevent an episode. It is with evidence such as this that can influence our vote for nanotechnology to monitor our CHF patients, seeing that it appears to be a viable choice in monitoring and has the capacity to decrease the occurrence of visits to the emergency room and subsequently readmission to the hospital. However, in considering this technology, we must assess what aspect of the nanochip can lead to unwanted circumstances. One particular environmental factor, the probability of toxicity, needs to be investigated. Research provided by Staggers et al. In 2008 also makes mention of nanomaterials causing inflammatory responses within the body, and in some research studies, incidences during testing phases found that the particles had the ability to pass through the blood-brain barrier. In an article entitled Nanoparticles and the Dark Side of Nanotechnology with Reference to Healthcare, authored by Sharon and Sharon in 2014, evidence brings to our attention that nanotechnologies, including nanochips, are manufactured in several different element variations, which at times can be toxic to human health. Sharon and Sharon make mention of the hazardous complication to both the environment and to human health in respect to the bactericidal property of silver nanoparticles, SNP, used in creating implantable nanotechnology. They state that a prolonged exposure to silver nanoparticles can cause permanent blue discoloration of the skin and discoloration of the eyes, along with soluble silver being toxic to the liver, kidneys, and can alter one's respiratory, intestinal, and blood cells. With complications such as these, harm will reach the patient and a positive outcome will be unlikely. As with any evidence-based practice or program, the DRHA committee evaluates the end result must always be what is in the best interest for the patient in order to have patient-centered and driven care. We as a healthcare team must consider the appropriate ethical and moral choice when delivering care and treatment options to our patients. As stated in 2006 by R. Simpson in the publication Ethics and Information Technology, How Nurses Balance When Integrity and Trust Are at Stake, Nightingale set the standard for our profession to do the ill absolutely no harm. We must keep this wisdom in the forefront of our thoughts when implementing practices, protocols, and programs. Katie?
Thank you. And also, as a case manager for this organization, I am interested in how to prevent hospital readmissions and the effect readmissions have on a facility. According to Graham, Tomkavage, Salek, Skiandra, Davis, and Stewart, in an article in Medical Care Journal published in 2010, a total of 17.6 of all Medicare hospitalizations are due to 30-day readmissions at a cost of $15 billion. Though nanotechnology would allow providers to receive complete and real-time data, it could flag a provider with trends in weight gain, heart rate, or blood pressure. Accurate post-discharge monitoring could allow physicians to catch a problem with the CHF patient and intervene before the emergency room and a subsequent hospitalization. An article by Staggers, McCaskey, Brazelton, and Kennedy in Nurse Outlook Journal, published in 2008, says that nanotechnology can affect a clinician's critical thinking and decision-making because better and more targeted data is received. The nanotechnology would allow CHF patients who don't have help at home to record and relay accurate data to providers, which would hopefully reduce hospital readmissions and improve patient outcomes. The nanotechnology also guarantees accurate data collection where family members or patients themselves may not. Fairweather and Rogerson in Medical Informatics Journal 2001 points out that inaccurate data collection may lead to doctors conducting unnecessary duplicate tests with direct adverse consequences to patient welfare. So all in all, nanotechnology could greatly improve follow-up monitoring and is a great alternative for those patients who don't have help at home and possibly can't afford to have a caregiver or a nurse come into their homes.
Thank you, Katie. As you can see, there's a strong need for decreased readmission rates in this and all healthcare organizations. A systematic review performed by Kansegara et al. In 2011 demonstrated that many readmission risk assessment tools have been created and utilized, however, when applied to a clinical setting, have been unsuccessful. This needs to be considered in addition to the information we have presented today when faced with the challenge of decreasing hospital readmissions related to patients with congestive heart failure. Thank you for your time and have a great afternoon.